Hello, my name is Frances Reid and I'm Programme Director for the World Ovarian Cancer Coalition. As part of our event, Ovarian Cancer, Better Data, Better Outcomes, I'm today going to be talking to Natalie Heriot, who is Coordinator of the Australian National Gynae-Oncology Registry. She has a background in public health and has worked on other Australian clinical quality registries. And following a pilot programme, the full-scale National Registry for Ovarian Cancer recently got the go-ahead, and it offers the potential in years to come to quantify best practice, drive improvements, and potentially benefit individual patients. You must be absolutely thrilled to have got the go-ahead for this work. Congratulations. Before we get into too much detail though, can you give us a bit of context of the work in Australia?
Thank you, first of all. We are pretty excited that we have the go-ahead. We have funding to expand the registry from the pilot phase. So to give you a brief overview, the field of gynecologic oncology in Australia is very small. So there are only about 50 gynecologic oncologists across Australia and New Zealand. And so with our population distribution being so spread out across a big area, there's a concern that there are many people who are not getting access to specialist care. So only gynecologic oncologists, those with that particular type of training, are able to perform the debulking surgery that is the mainstay treatment of ovarian cancer. So looking at quality of care is really important because there are limited places that people can go, or women can go across the country to get this particular surgery. And there's concern that, of course, those who are in rural areas and don't have access to these major centres or to these main clinicians might be getting their care performed by, or their surgery performed by someone else, or opting for a different type of treatment, so not getting the best practice.
And how much data has been collected on women with ovarian cancer in the past?
So with our registry, we've been operating for about 3.5 years with the pilot. So that's only about 10 to 12 of the major specialist centres across Tasmania, Victoria and New South Wales. So we have about 600 patients currently with epithelial-based ovarian cancer. But with the grant that we were awarded earlier in the year, we have the potential to extend across the whole of the country and to start collecting those sites that aren't specialist units.
Okay, but before even the pilot, was it just data that was collected within hospitals?
Oh, of course, yes. So the registry started with a model that is that's not frequently used, or hasn't really been used with other cancer registries that we're aware of, which is that we source data from existing data sets, so clinical databases maintained by clinicians in their private rooms, or unit databases maintained at public hospitals. So the previous situation was everyone was collecting their own data, but in a very specific setting to their own work. There's no national way to, or even state level way to compare and contrast across hospitals, at least not to an extent that's meaningful clinical data. We can look at epidemiological data in Australia. We have cancer registries, that we report statistics, the incidence and prevalence of cancers, but we don't have that next level, how many patients are actually being diagnosed with each particular stage of disease, and how are they then being treated once they are diagnosed. So the registry really pulls together that clinical in-depth detail up to the level of, or almost to the level of, the epidemiological data.
So I imagine there were a lot of challenges because everything is so widespread, and because there are small pockets of centres of excellence, as it were. Has it been likely that different practices have built up in different centres?
Yeah, so there is that potential. Can't say with certainty. The registry obviously is too immature to be able to say, but it is at the upper level from what we can see now and what we understand anecdotally. It's believed that there is variation in care. So through our pilot, we only looked at those specialist centres that I mentioned, and there's already variation in the care that they provide. And in moving forward, we have had all our clinicians for the ovarian cancer module, as well as the other gynecological cancer modules, get together and come up with what they think is the best practice care. And hearing those conversations, all the clinicians sort of debating and talking about the different guidelines and what their practices are, it's really interesting to see that it can be quite different, especially across the states where our systems vary. So some form of imaging might, for example, be quite common in one particular public hospital in one state, but not commonly done in the other state, for example.
The pilot was clearly successful because you now have major funding to take this forward on a sort of national level. What were the key points to success for the pilot?
I think the main thing for the pilot that helped us succeed with the pilot was the clinical engagement and the engagement of the Ovarian Cancer Australia, the patient advocacy group for ovarian cancer patients in Australia. So with other registries, they have started from a research level or from a government level, and there's a very different, we had a very different experience because we started with clinician buy-in. So when we weren't going and saying to people, or at least we weren't giving the impression that we were going and saying, there is variation and we need to do something about it. It was very much all the clinicians getting together with Monash Uni researchers and Ovarian Cancer Australia and the Surgical Society saying there is variation in care for lots of very valid reasons, not just to do with the quality of the care that each clinician is providing, but there are a lot of circumstances that affect that. And so we started from a really good space that we had all these clinicians who were willing to go through that process and actually figure out what it is that we should be measuring, defining best practice, what our quality indicators should be, and quality indicators, for those people who don't already know, the measurements, so what we report quality of care against, I guess. Like we use the data to report against quality indicators, and they represent what is considered to be best practice in a measurable way.
Okay, so what happens next? Now you have this funding and the go ahead to spread wider.
So with this funding, which is, I should mention, part of the Medical Research Future Fund from the Australian government, this funding allows us to try and recruit all the other hospitals around the country, or the other specialist gynecological units. And then once we get the major units and we get the major hospitals who see a lot of ovarian cancer patients but might not necessarily have a specialist unit, a gynecological oncology unit, we then get to approach the sites where there are very, very few patients, but anecdotally, so I can't say for certain, it's very strongly believed, and it's widely reported, unofficially widely reported, that there's variation in care for those people. So you might have somebody who's out in a rural site, somebody who lives in quite a rural location, they'll go to maybe even a large regional hospital, but more likely a smaller one, and their cancer might be discovered during a surgery, routine operation for some other, they thought it was something else, and I'm sure this is common across the world. The cancer will be an incidental finding during the surgery, and then the issue is if somebody tries to start taking the cancer out and doing a debulking procedure, it's not likely to be a gynecological oncologist, and so it's very, very likely that patient will then get stitched back up, and they'll have to heal, and then they'll get sent to a gynecological unit. And one, that has all those implications of travel and distance from the families and things like that. But then also they'll go to those units and they'll have to get care, they'll have to have somebody reassess their care, and they'll probably have to go back into surgery, and it changes everything.
Yeah. And it's a quality registry, so you're going to be collecting things like PROMs, so patient reported outcome measures, and also indicators about the sort of experience and psychological aspects from women.
Yes. So I should have mentioned that before. The other really exciting part of this grant is not only can we increase our state capture and improve our quality of the data that we're getting, we get to collect patient-reported outcome measures. So part of the grant allows us to incorporate a really a much more focused consumer aspect. So it's currently very surgical, very clinician heavy. So it would be really nice, or it will be really nice to be able to get OCA far more involved, consumers more involved, and actually find out the aspects of care that are of most importance to the patients themselves, and find out more about how they're feeling and how their experiences of quality of care were, and how maybe that differs from the clinical quality of care.
Okay, and there are other examples of clinical quality registries in Australia in oncology. What have they been able to do? You've worked on some of them, haven't you?
Yes, so I've worked on the lung cancer registry and the upper GI cancer registry. And I work in a team where several clinical quality registries are managed, and within a school, in a university where there are even more registries. So the really good example that we provide to people of the success or the potential of clinical quality registries is the prostate cancer registry, which started out in Victoria in Australia and has since grown to the whole of Australia, and actually it's international now. And one of their really key findings, a really good way to illustrate how registries work, is they found in one particular major centre where you would expect good outcomes. I mean, not to say that you wouldn't expect good outcomes everywhere, but, you know, a major centre where there's a lot of specialists, they're doing a very high volume of surgeries, you would think that it would be better than somewhere that does maybe 1 or 2 operations a year. They found that there was a higher than average, or, you know, more positive surgical margins. So a lot of people were ending up having to get radiotherapy, or more radiotherapy than planned, because there was residual disease after the operation. And so the registry investigated, thinking this is, you know, obviously this is out of the normal range. We report our data in terms of standard deviations from the mean. So this one was flagged as an outlier, and, you know, after doing the whole process of checking the data quality, making sure that the registry wasn't wrong, you know, doing all of that, the site finally investigated. I mean, there's a whole process, an escalation process. But by the time the site got around to the site having to look at this, they uncovered that there was actually just a fault in their scheduling. So that a lot of their junior doctors were doing operations and they weren't properly supervised. So they were being overly cautious, and then they were taking slightly less of the tumor, or, you know, taking less tissue. And then obviously with pathology, they realized that the margins were still positive. So there was still tumor there in the sample, and no clean tissue surrounding it. And so those patients were going on for radiotherapy.
So it's not really about naming and shaming at all, but
Oh.
it's about helping people improve towards the standard of sort of care. But you don't have any powers of intervention as a registry, do you?
No, so it's definitely not about naming and shaming. We don't have the power to sort of, you know, I guess, dog people in. It's very much a research tool, health services research tool, where we just take the data that most hospitals will collect over time. You know, a lot of hospitals perform audits in many areas of their care, and they look at how their numbers change maybe over time, and how their site performs against maybe like a standard, like an average, like a national average or international data. But there's no way to actually compare it and think about, there's no way to compare the data across hospitals, you know, between hospitals, between private and public, because all our systems are so different. And in many ways, there are a lot of sites that would get poorer outcomes. So, you know, they would look like they were performing worse than the rest, simply because they're getting the sickest patients. So, you know, you get a specialist hospital receiving all the worst cases. And then if you were looking at outcomes, say, just on survival, you would then see that certain other sites, you know, maybe their patient survival rates are much better, but that's because they're ending up with the sort of quote unquote easier patients to deal with. So yeah, we collect all the data, we, you know, manage it in the same way, we risk adjust it, and then we report it back in benchmarked reports, and we don't name anybody. We just tell the site, you know, where they stand in relation to their counterparts.
I mentioned in my introduction that this registry has the potential to actually not just improve overall care for women with ovarian cancer in Australia, but has the potential to actually help individual women get better care?
Well, the hope is that with the collection of patient-reported outcomes, that we can link patients to support services. Because currently there's, you know, there's a lot of support services out there, but there's only so many ways that patients find out about these things when they're diagnosed, especially if they're coming across in, multiple different hospitals, and it's very the process of care, process of being diagnosed and treated is often quite different depending on where you are and what state you're diagnosed in. So because we're looking at the whole population of interest, so every woman with ovarian cancer, we have a potential to link them into support services and tell them that there's, this information available to them, the people and organizations there to help them out. Because in theory, we're finding out about these women early on in their diagnosis. So that's when you want to link them up to support services. But we also, in collecting patient-reported outcome measures, understand that that's quite a burden on patients. We're asking something of them. With the clinical data, we just ask them if they don't want us to collect their data, and they don't really have to do anything. The sites will then send us the clinical data. But with patient-reported outcome measures, you're directly asking patients to give you answers and take the time, and especially if they're particularly unwell, it's a big burden. It's a lot to ask to have nothing in return, because as you say, clinical quality registries are really about improving care for future patients. So the idea would be that we, when we collect the information, we then can provide back, a link to any kind of support service that is relevant to this person. But we obviously can't intervene. That's not our role. We're not clinical specialists or anything like that. We can't, there's only so much that we can do, and we do have to keep in mind the ethics of the whole process, in that if somebody were to report to us a very serious symptom, we obviously have duty of care to report that to someone. So if a patient was to report that they were suicidal, we can't just sit on that information, but we're also not in a position to help them directly. So there's that whole sort of spider web of it's just a very complicated area to work out.
What sort of timescale are you hoping to be able to get sort of really good data from across Australia?
So we should hopefully in a couple of years be able to report on the major centres, if not, within the next 12 months for our current major centres that we have on board. And then, by the end of this 5-year grant, ideally on a much bigger scale, and we should be able to report back some actual quality indicator reports. So they're the risk-adjusted benchmark reports.
So finally, for anybody else sort of beginning to enter into this world or think about, is this possible in our country? What would you say are the key elements that people need to get in place, and that the sort of ethic that they need to adopt with the project?
I suppose I would say that number one would be to ensure that you've got a multidisciplinary approach. You've got support from all the different areas that you need. You need support from the clinicians, because you need to know what is best practice, what is considered to be best practice that might not be quite so clear cut through the literature and the guidelines. You need to, and also because they're the ones that are being sort of assessed in and then, but then the hospitals, they're technically the ones that are getting these reports back saying your patients are doing better or worse or the same as other patients. So you need the health services support. You really need the consumer support, because, if we're doing this to improve patient outcomes, we really need those patients to be involved and tell us what outcomes are of the greatest importance to them, not just the ones that are of the greatest importance to the surgeons. And then the other thing would be to have a really good idea of how your ethics and site governance process works in your country or your state, because that was definitely a massive hurdle for us, in that getting ethics and site governance approved was very complicated. Registries weren't necessarily recognised. So across, multiple ethics committees, they would make us submit it as a high risk application, which is the equivalent of a clinical intervention like a clinical trial with an intervention, because they considered the risk of us as an external party seeing the clinical data, seeing private data from patients to be a high risk. So I think it's also, you need to know what the government and what your ethics system is like in that regard. So when we started, it was quite complicated, but over time, like, the Australian government is slowly recognising registries as very important, and that's sort of how we got our foot in the door with the funding, and how future registries are probably going to have a much easier time getting off the ground.
And I think also bear in mind, it will take time.
Yeah.
Well, congratulations on a successful pilot, and good luck for the rollout of the National Gynae-Oncology Register. Thank you very much, Natalie.